Today I'm here with Dr. Timothy Roberts, and you did a really interesting study that was published recently in, I believe it was the British Journal of Sports Medicine. And
Mhm.
I read it and I was really intrigued by it for a couple of reasons. First of all, would you mind just summarizing what you did?
Yes. I was in the military, and my coworkers in the military. We examined athletic performance among military active duty service members who underwent a gender transition while on active duty. So we looked at their performance before on physical fitness testing by the military, before and after their transition, and we could measure how their transition affected their athletic performance, both in 1.5 mile run times, how many push-ups you could do in 1 minute, and how many sit-ups you could do in 1 minute. What we found is that our transgender men, so people who were born female at birth, started testosterone and progressed. They caught up with the rest of the people who were born as men in terms of athletic performance about a year after starting testosterone. For transgender women, people who were born male, but then transitioned to female, start getting on testosterone blockade and starting estrogen, their athletic performance in push-ups and sit-ups, so strength events, declined to the level of other people who were born female at birth after about 2 years. Runtime also declined among these people. However, they still retained a advantage in runtime over the women who were people who were born female after 2 years on hormones.
Which is a fairly long time. I know that there's sort of been debate in various
Mhm,
athletic organizations about how to work with people who identify as transgender to allow them to compete. There are a number of legislative
mhm,
efforts right now trying to suggest that that even if somebody goes through these, testosterone suppression and taking estrogen, that they still have a competitive advantage over biological women. I was curious, do you feel like your study can be used to inform this debate?
That is my hope. Right now, the International Olympic Committee and World Athletics, which is the governing board for all the world championships, their previous guidelines suggested people should be on testosterone suppression for 1 year
Mhm.
prior to being allowed to compete with in women's athletics. My study says that that's probably not long enough, and that also goes along with other studies that showed that demonstrated that transgender women retain some of their strength advantage for at least a year, but it does decline over time. These same guidelines say that transgender men, people who are starting testosterone, they can flip over and go to compete with the men as soon as they want to because they don't perceive that they're going to have an athletic advantage over the other men. I think that my study, we do not have a long enough time to really know when, if ever, that the run times become completely equal. However, with strength events, 2 years they become equal. For run times, it's how much that is their just retained advantage due to how they were born. So people who are born male and go through male puberty tend to have thinner hips and longer limbs, and that provides them an advantage in athletics. However, even among uh, uh, really competitive female athletes, they tend to be tall,
Mhm.
thin-hipped, have long limbs. And so, but we're not preventing them from competing either. And so, if you ask me, is the average man the average man who undergoes, the average person who's born male and goes through gender transition, they're not going to be a world class athlete when they start to compete in female athletics. There's probably a several thousand highly competitive men who are faster than the fastest woman at the 100-meter sprint. Um, and if one of them decides to uh, go through gender transition, they may retain their competitive advantage over the woman's the world's best natal female athlete. But for the average person, that is not how it turns out because the average highly competitive, highly fit female athlete is probably better,
Right,
better
than
than
the
the
average.
average male
Right.
guy.
But you noted a 10%, around a 10% difference in run speed, which is significant.
Oh, absolutely. After 2 years, there is an average 10% run speed advantage over after 2 years between the average male who transitions to female and the average woman in the Air Force.
Right.
That competitive advantage is declining over time the longer they're on hormones and testosterone blockade, but we cannot say that they have completely transitioned. An interesting example in the United States that a lot of people talk about is in Connecticut, I believe.
Yeah.
There was a federal lawsuit saying that saying that the transgender women athletes coming to compete with the women's female athletics is depriving uh, natal females of advantages as far as competition and scholarships, etc. In that sort of yes, when these two people that were subject to the lawsuit began social transition and transitioned to compete in women's athletics before starting hormones, yes, they had an advantage over the other female athletes and they dominated the sport. However, when they started hormone therapy, their performance declined, and actually, one of the women who was part of the lawsuit actually beat both those transgender female athletes in an athletic competition in the last year, noting that the high end runners going to the gender transition, their advantage declines over time. It continues to decline. Um,
So that's
what I think
interesting
is one of the things
because
that's yeah, please,
oh, that's
yeah.
interesting because initially the two boys that were competing in the girls track events hadn't done anything medically. They just had socially transitioned. So I
Hmm.
think that's something
Yes.
that's really important to note because there is this sort of balance between people who just claim to be transgender and haven't done anything to actually medically transition competing against girls. And that seems like a very different proposition. I was wondering if you could talk about the specific physiological differences between men and women and how those help biological males and how they may or may not be changed by hormone treatment.
Certainly. So biological males or people exposed to testosterone have higher red blood cell content. So they tend to have a little more cells to carry oxygen to their muscles. They also tend to be able to build up muscle bulk, and they tend to acquire muscle. First, they tend to be stronger because they respond more to weightlifting and performance than they training advantage, which is why people who are cheating in athletics have extra testosterone.
Mm.
Um, with professional athletes who want to have an advantage, take extra testosterone because it makes them stronger and bigger. And so the strength advantage in muscles, the advantage in um, red blood cell content, that goes away when you block the effects of testosterone. Those advantages decline over time. You can retain some of it for longer by training, but it slowly declines because in the absence of testosterone, those advantages go away. Now, for male puberty, on the other hand, men and women grow differently during puberty. Women tend to gain hips; their hips get wider to prepare them for carrying children in childbirth. Um, Women and they maintain those advantages. Once you finish growing, your skeleton is what your skeleton is, and so males tend to have different muscle attachments locations on their legs, a little bit longer limbs, and narrow hips, and that provides them a um, just an anatomic advantage that doesn't go away. So if people go on pubertal blockade early on in puberty before they grow and then transition, they probably don't have any of those advantages because they never went through male puberty. For people who have gone through male puberty, they are where they are.
Yeah.
um,
And that's
and so
interesting because
also,
oh, go
yeah,
ahead.
go ahead.
Oh, I was just
No,
curious
please.
because one of the things that I've noticed, as I've been investigating how different
Hmm.
people medically transition, is that there really isn't a uniform prescription for the amount of testosterone given to girls or the amount of estrogen given to boys or the various, puberty testosterone
Mhm.
suppressing. So and I was wondering if in this case, if the military does have very specific guidelines, or if it still is sort of up to the individual doctor and patient to determine, how much testosterone are you going to give the woman, how much estrogen are you going to give the man?
So there are two major guidelines that most people use. There's the WPATH guidelines, which is the dominant transgender guidelines that are used in Europe. There's the Endocrine Society guidelines, which are the guidelines that are typically used in the United States. Most of the providers in the military are definitely using the Endocrine Society guidelines, and so that is typically how people dose. Now, anytime you're practicing medicine, it's always a conversation between you and your patient where you take the best available evidence and apply it to your patient's situation. When you're providing transgender care for somebody who has what we call gender dysphoria, or they have a strong um, adverse reaction to their physical development, or they have a strong preference for the characteristics and appearance of the other gender they feel in their heart. For example, for me, if I feel that I'm a woman, I'm like, my lack of breasts, my excess body hair are both very distressing to me. My extra parts are very distressing to me, and I want the other parts. Now, to address people's gender dysphoria, sometimes it's just as much as give them the name. If you say, we're going to use a name you choose, the right pronouns, clothing, let you have that gender role, that addresses their gender dysphoria. They don't want hormones.
Mhm.
Other people want hormones, but not surgical correction. Other people want hormones, surgical correction, and how much hormones they obtain is really, and how far they go down that path is dependent, because we're trying not to make them an anatomic male or make them an anatomic female from the outside. We're trying to address their emotional distress to relieve that, to allow them to be the person they are inside, so it all aligns. Uh, and that means different things for different people. Now, in answer to your question, the Biden administration guidelines have said yes, so people should be able to compete in the gender they identify with as soon as they begin social transition. Well, I think that is very affirming to the patients to allow them to experience what life is going to be like before they start anything permanent, such as gender affirming hormones, or especially before they're doing anything surgical. Uh, on the other hand, those people do have a tremendous athletic advantage, especially people who are going from natal male over to female in women's athletics. Those men are going to have a large advantage when they first transition. And so, probably immediately on social transition, that's probably my take. This is purely Tim Roberts'
Mhm.
take, is that that's probably unfair. I think there probably should be some level of social transition and then medical transition to decrease that level of advantage, and before allowing them to compete in women's athletics, because women's athletics should be a protected category, to allow women the full advantages of competing and team camaraderie and learning how to put the goals of the team before yourself, or learning how to sacrifice the immediate stuff for the benefits of a future performance. Those are really important life lessons you can learn in athletic performance, and some people really like that. And letting a group of people who have a decided advantage come in, um, and having them dominate the sport is unfair and deprives them of a experience that they should be able to have.
As well as
On the
scholarships and
other hand,
career opportunities. And I
yeah,
think that that's
and
one of the concerns the Connecticut girls had.
yes, and I agree with that. In the first year, that's probably very true. On the other hand, those same advantages with competing in sports also apply to transgender individuals, and we want to let them uh, experience everything they can. My personal feeling is immediately after social transition, but after a year of medical transition, that's probably okay. Of testosterone suppression to female levels, and you've been on hormones for a year, I think that's probably an okay starting place, knowing that you have an advantage when you start at that level, and that advantage is going to get smaller, 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 smaller the longer you're on hormones, and the more and more feminine appearing you will look. Because in the first year on transition, you're not seeing a ton of physical changes. After a year on hormones and estrogen, uh, people are starting to notice the fact that you have breasts, the fact that your face has become rounder, your muscles are getting smaller, you have less hair. And so you're going to have more and more feminine appearance. So it's going to look weirder and weirder for you to be competing in male athletics. Um, but however, on the other hand, a lot of the rules that say you should never be able to transition, or you must always compete in your sex in your birth certificate, ignores the fact that we have transgender men who are on testosterone.
Well, and
And
that's
they're
what
in,
I was
if they're not
wondering
allowed, good.
is if there's a woman who, probably not me because I'm a small woman, but if you had
Right.
a, a tall, fairly sturdy woman who
Hmm.
got on testosterone, could she just keep upping her doses? Because you mentioned that when men wanted to be stronger, they could take more testosterone. So could a woman in theory take a lot of testosterone and gain an unfair advantage in that way?
Of course, the East German Olympic team has proven that several times.
Oh
The
yeah.
Russians have proven that. Um, However, for medical treatment for transgender, your target is to try and get the person up to adult levels of their desired hormones. So for somebody who's a transgender man, we're trying to get them to adult male levels, to in the range of adult males, to where they're getting facial hair like they prefer. They're getting muscles. They're redistributing their body fat from being on their thighs and their behind to their tummies, like all the other guys, so they can pass. So you're not trying to get people to super physiologic or way high levels to athletic advantage. You're trying to turn them. You're trying to give them the same levels as everybody else of that gender. And going the other direction, we're trying to get testosterone levels down to female levels and estrogen levels up to female levels because that produces the results that these people want. Speaking of testosterone, there are women who have elevated testosterone levels from medical problems such as like polycystic ovary syndrome, which is a common problem where women have elevated testosterone levels. So they tend to have hair and male distribution, they tend to have irregular periods, weight gain, high blood pressure, cholesterol problems. Um, what they've noticed in competitive athletics at the world championship level, about 25% of the female competitors at the world championship level had elevated testosterone levels consistent with polycystic ovary syndrome versus 2% in the general population.
Oh wow.
So it's very, and for also they had women who had testosterone levels in the top third of all women competed way better than women who had testosterone levels in the bottom third at the world championship levels. So people who have testosterone from natural processes also have an advantage. So there's never really been a totally level playing field.
So would you
I mean, some
recommend
people just
for
have.
there to be a level playing field, that competitive events are based on estrogen or testosterone levels?
I well, I think you should probably have. I think you should allow people to compete in the gender they identify with. However, for transgender women, I think they're testosterone at the recreational level or the youth level. Probably 1 year on suppression is probably enough to make the playing field level enough. Because at that level, we got people who have, if you're a father's a footballer
Mhm.
and you grew up with the football in front of you and you're kicking it around the house and you've been trained, had the best training and the best advantages and the best equipment, you're going to have an advantage at the youth level that somebody who just got off the couch
For sure.
to play has. So there's a much broader range of abilities and things, and that probably levels out the effects of the retained advantage that's going to decline. Now, at the elite level, I think it needs to be at least 2 years of hormone suppression down to the level of all the other women testosterone to get down to the level we're applying to everyone. Uh, World Athletics said 5, which is about the level that the World Athletics suggested is still 2.5 times higher than the level of your average female. But you got to draw the line somewhere. And so I think it's a fine line that get their testosterone levels down to the level that the other competitors they're competing against are, keep it that way for at least 2 years, and then let them compete. Because at the elite level, um, there's people have fairly equivalent facilities, training, equipment, and so that little extra bit from testosterone probably makes a difference. And so I think it needs to be balanced on the um, advantages they have and the level they're competing at and the stakes of the competition. Winning a gold medal at the Olympics means a whole lot more than me taking first place at the fun run at
That's
my local
true.
park.
Yeah, that's true. However, if you don't win at the fun run, you might never make it to the Olympics. And so there is that sort of that snowball effect that if somebody is able to get
Mhm.
into it, that they might. Um, and I don't know.
Yes.
One of the things that it keeps coming up to me as we're talking is
Mhm.
that this approach to setting standards for hormones is going to encourage
Mhm.
people to take hormones if they want to compete. And what I keep thinking is rather than encouraging hormones, which do have deleterious effects over the long term, why not push for allowing non-gender conforming people to compete in the categories in which their biology suggests they should compete in? So if you have a man who prefers to wear lipstick and a dress, let him wear a woman's bathing suit and have long hair, but still compete against biological males so that they're not damaging their bodies with hormones that ultimately are going to have long-term consequences.
Well, the hormones can have long-term consequences, but they tend to have fairly similar long-term consequences to all the other people that have them. So the people who take estrogen and testosterone suppression tend to have the consequences associated with estrogen that women experience. And the people who take testosterone tend to have the consequences that men experience.
Without
So
the
people testosterone.
suppression, though, the suppression of those suppressive drugs, from my understanding, can have some pretty serious side effects. The testosterone.
Uh, the testosterone suppression drugs. The uh, so two different classes. So there's medicines like spironolactone, which are there to block testosterone receptors. If you just block it, and then there's blockers, which prevent generation of any sex hormones.
Mm.
Now, the generation of any sex hormones, if people are on them, that is like going through a chemical menopause. So people tend to have the same thing that a more experienced woman would have when she reaches a certain age and her ovaries stop. So they lose the hormones. They tend to get hot flashes. They can lose calcium from their bones. So yes, that does some negative effects have some negative effects if given for a long time in the absence of other sex hormones. Now, if somebody's on those and then they come off of them, their body's natural processes kick back in, and then they make sex hormones, and their things and those problems correct themselves. They correct themselves. Block so, or if they start gender affirming hormones, so if somebody gets their testosterone suppressed, yes, they're losing calcium until they start estrogen. When you start estrogen, that makes them have calcium, puts calcium back into their bones. As long as they're taking it, they don't necessarily run into problems with osteoporosis. Now, we do worry about mood swings. We do worry about hot flashes, and you can address those in younger children with very small doses of hormones. And we don't worry about that as much as we do in older people because most of our younger people don't get breast cancer. Heart disease
Right.
isn't really a
It
problem
just
for a
it
teenager.
just it's so confusing to me though, because these are expensive medications. We have no longitudinal studies
Mhm.
about their effects. So we can talk about it appears to be, but anecdotal evidence actually suggests otherwise. And so my concern is that we're actually encouraging gender nonconforming people to medically transition when instead we could be pushing against gender stereotypes and allowing people who are gender nonconforming a lot more freedom than they're getting now. Because now the message is, if you're gender nonconforming, you should transition, and therefore, you can present as the opposite sex and have those, um, you know, same experiences. But that to me is such as I mentioned in my email to you, I had gender dysphoria as
Mhm.
a kid. And I am
Mhm,
so thankful that I didn't grow up today because I would have been pushed to medically transition. I have no
mhm,
doubt. My gender dysphoria was incredibly severe. It was the result
mhm,
of a sexual assault, and I was like, oh my gosh, um, I don't want to be a girl anymore because look what happens to girls.
mhm,
And I've heard a lot of
right.
girls who've had this experience, and so it seems like if we're gonna push kids into medically transitioning, if they have those feelings, that's a much more dangerous route than just saying, you know what, it's okay to present as it's okay to assume those gender stereotypes of the opposite sex, and then you it seems like that would open up the world for gender nonconforming people, to have freedom in a way that we're sort of limiting it now.
Yes, ideally, it shouldn't matter,
Mhm.
but people do perceive that it does matter. Now, the hormone issue with athletics is only an issue if we want them to compete, if they want to compete with the other, if they want to compete with the other women.
Mhm.
And so, for people who are not involved in athletics, they don't necessarily need to transition. For people who have a history of trauma, which is why part of any transition for a uh, person under the age of 18, for sure, is the guidelines say they have to be seeing a gender affirming therapist. They have to have explored that gender role, have had real life experience. And so, for those people, we're looking for persistent, consistent, and insistent uh, gender dysphoria. So it's always there. It's always a problem. They always insist on it being that way. Now, for people with trauma, we definitely have to worry about that because that is a very common thing. Um, I saw a patient in my clinic last month who had that sort of trauma, and their trauma and their gender dysphoria arrived at about the same time, which was right around puberty. And so, but they had not engaged in a good therapeutic relationship with the therapist and truly dealt with any of those things. We're like, we're not doing anything. Um, we
Right, and
may
in
put
my
you on
case, I
something so you
was
don't have
very
periods and
insistent and consistent, persistent from the
right.
time I was, 6
Hmm.
years old until I hit puberty. That was a, really long time period.
Hmm.
Um, and again, I have this concern that it's, internalized homophobia. I've talked to a lot of women who
Hmm.
resisted,
Hmm.
because it turns out they were lesbians, but they went to
Hmm.
therapists who just automatically affirmed them and sent them on this pathway. And so I feel
Hmm.
like there's a lot of these cases where, anytime we are encouraging the medicalization of these feelings, we're sort of
Hmm.
potentially going to undermine the health and well-being of kids who look at these athletes and say, well, if I'm going to compete, I
Hmm.
have to medically transition, rather than saying, well,
Hmm.
if I want to compete, I want to compete in a world where if I want to wear a girl swimsuit and I'm a boy, that's okay.
Hmm. So for people who uh, it's trans, so people cross-dressing, so people who enjoy the clothing and appearance and gender role of the other gender, but internally they are not distressed when they look in the mirror in the mornings, that should be encouraged. They should be able to wear what they want and then compete with what they have biologically. uh, However, take care of people who are, close their eyes the entire time they're in the shower because they can't, and because they can't bear to see any of their parts when they're not having any clothes on. Those people uh, tend to have a lot of distress and they want to transition. Now, we don't do anything permanently. Anybody before puberty, you don't do anything medically. You get them into a therapist and you work on all the things that are going on. When somebody hits puberty, if they have a very strong reaction to what's going on at puberty, we can say, okay, we can consider using puberty blockers to halt any further development and put a pause button on and have you definitely work with a therapist to make sure this is the right path you're going on. Um, and then when people are uh, in the thoughts of their parents and the medical team, that they're old enough to understand the long-term risks and complications of the therapy, generally around, most people can do that around age 16, but not everyone. So around age 16, we're like, okay, this has been going on for quite a while. You've been living the role. You're out to everybody else. You are happier this way. but you're still very distressed by these body parts and you're having problems passing, then at that point, we consider doing gender affirming hormones. So we don't do anything permanent to people until, you know, late 15, early 16, late 15, 16 years
So you
old.
don't give puberty
When,
blockers to 8-year-olds? Because I know Johanna Olson Kennedy has suggested, she actually put in
yeah.
her revision to her study, and she's now giving them to 8-year-olds, which is, it would have affected me for sure. And there are a lot of kids, I think, at
Mhm,
that age. And those are, I mean, when I look at the side effects of Lupron, I am stunned. I know there are a
mhm,
lot of women who took it for endometriosis who have
mhm,
actually asked the FDA to revoke it as a medication because it's had such
mhm,
serious side effects for them. And
mhm,
so I know that typically doctors who are affirming talk about the fact that they don't do anything permanent until kids are maybe 15 or 16, but based on the information that I'm seeing,
mhm,
that's not true. That they're, kids as young as 8 years old are getting puberty blockers and even cross-sex hormones at times. And so I know at 8 years old, I certainly wasn't capable of making those decisions. And at 15 or 16, I actually went into my doctor and asked him to give me a hysterectomy, and he wouldn't do it. And I'm really thankful
mhm,
because I have three
right,
beautiful kids now. And so, and I know my situation
mhm,
is not the same as everybody else's, but I'm hearing enough of these stories coming out, and having experienced that gender dysphoria to the point where I actually took rocks and pounded them on my vagina, had
mhm,
that much hatred towards my female
mhm,
body. That
mhm,
to me, the litmus test for when to give these drugs shouldn't necessarily be a dislike of your body, because to me that indicates, you know, a disconnect. We have like, we are our bodies in some way, and to figure
mhm,
out what is causing that disconnect, rather than assuming that there's some kind of essence of gender that a person can have, which to me is really inexplicable, because I've never felt like a woman. I don't even know what that means. I know biologically I am a woman.
mhm. Okay. Yeah. So puberty blockers can have some side effects. Um, However, if you stop them, the person progresses down the pathway that they were on originally. So you're putting things on pause. Now, people can have some can have some mood effects with that, can have some physical symptoms along with that. But but you're balancing that against so if you have a person who is suicidal with their gender dysphoria and really distressed or engaging in self-destructive acts, we find that if you stop that development while they work with a mental health professional, that can be very helpful in preventing them from engaging in any harmful, any self-harm. Knowing that
You're
if they stop,
suggesting that a suicidal patient be given the drugs that they want to mitigate suicidal tendencies, which, based on my experience with mental health, is not typically something we do, because when somebody's suicidal, they're not capable of consent.
That's why so they say if there's people having recurrent suicide, we're treating them with antidepressants, treating them with therapy if part of their issues appear to be gender dysphoria or worried about that. And one of the things they're really distressed about is their physical development that seems to be going the wrong direction for them. If you put a halt to that, that can be beneficial for some people in concert with getting permission from their therapist,
Right.
permission from their parents, and agreement with their therapist that they're in mental health team they're engaged with. Um,
And
Now,
my concern is that
some
you're
people,
inducing a developmental delay. And so kids who are already feeling disconnected with their body are going to be around peers whose bodies are developing and theirs isn't, which is going to increase that sense of there being something wrong with their body.
yes, but they have that in sense already, and if they're very distressed by it, it's very helpful. We find that their rates of suicide attempts go down if they're on puberty, go
Can you
down, and
send
their
me
mental stress
documentation
goes.
of that? Because I haven't seen anything that documents that.
Sure, I will. Yes, I will see that. I will get the. I will get the. There's one or two articles I can send to you
Okay, because
that
I've
show that
researched this and
that
I've
is
seen absolutely no
okay.
indication other than through self-reports. And if it's a
Oh
self-report, then
well.
I'm not convinced that it's going to be, a very valid study. But if it's, if you have something that actually has good data and methodological um, processes, then I'd like to see it, because I really haven't seen anything like that.
Okay. Well, for suicide ideation, whether you're thinking about suicide, we're really kind of stuck with self-report because
It's really
if
hard
it's all
because,
inside your
yeah,
head.
and I empathize with doctors, because I was suicidal as a kid. And again,
Hmm.
you know, I don't know what would have happened if they had given me puberty blockers, if it would have helped in the short term. But in the long term,
Hmm.
I know that one of the things that helped me, really the first time that I was happy in my body, was when I gave birth.
Hmm.
And suddenly I was
Hmm.
like, wow, okay, this body that I've hated all my life did this wonderful thing. And all of a sudden, I understand these breasts that I
Hmm.
have make milk to feed my baby. And they're not just these sort of like, obnoxious things that cause men to look at me. And so it had like this just
Hmm.
profound shift in my whole identity, I guess you could say. And that happened once my
Hmm.
body was allowed to sort of do what it was made to do, which is physiologically, as
Hmm.
women. That's one of the processes. And I'm not saying that every gender dysphoric person will have this feeling, but I do know that research,
Hmm.
from Ken Zucker and others, shows that when kids go through puberty, especially kids who, I think my situation was different. Most kids don't get gender dysphoria as 6-year-olds as a result of trauma. We're seeing that more as,
Yeah.
teenagers. And so I understand my
Hmm.
situation was different, but I also am just seeing that, all the research is showing that the vast majority of kids, when they are allowed to progress through puberty, actually have those feelings of distress resolved. And most kids have feelings of body dysmorphia, when they go through puberty, because it's such a profound change for these kids.
Yes. Many do. Um, However, many don't have distress where they're, yeah, yes, I'm distressed by these developments, but I'm not distressed by the fact that I don't have a penis. If you're a woman, you're getting parts that you feel should be there, and you don't have parts that feel that should be there. Now, for people that get puberty blockers, these tend to be the children who, age 3, they're arguing with as soon as they can address themselves, they reject all. Well, let's go the other direction. So they start as soon as they insist on going to the girls section and buying dresses, and they want to wear dresses, and they want to have long hair,
Yeah, my
and they
son
insist,
was
right,
like
calling
that.
me a
It's
boy.
amazing. Yeah, it's
And
very,
so
yeah.
it's and so for many of those kids, like 85% of the time, those kids, if they're supported by their parents and their parents are like, okay, sure, you want to wear a dress, you want to have nails, whatever, you want to cut your hair really short and run around and mix. 85% of the time, those kids, it all goes away. They settle out in their gender. Um, there are some people that do persist, and so if they have that issue and it gets much more severe when they hit puberty with development, then those are the kids that we say, huh, this is going on for years, this has gotten a lot worse with puberty, let's
Right. And
put a pause thing on
they're
sort this
likely
out.
gay kids. Would you say they're likely gay or lesbian?
I'd say that of the um, of the natal males, so people who are born male and they have gender nonconforming behavior in childhood, and they don't persist after puberty, many of them end up being gay.
Mhm.
For people who are born as women and gender nonconforming behavior and don't persist, not like 10-15% end up being lesbian. The rest of them just end up being women who prefer a more masculine gender role than what's being
Right.
offered to them by the world,
A lot of
and
them are autistic.
that's
Really.
okay.
Yeah. Yeah. I think the autism
There
factor
there
is
can't
really important.
I there is a higher I there's some observation that the autism that there's a higher rate of autism in people who have in people who show up with gender dysphoria. Whether that's these people are whether that's a connection between gender dysphoria and autism, or is just people with autism are less constrained by societal roles and their expectations of others, and they're much less likely to hide their internal state to conform with their parents want. An autistic kid's like, I'm just going to tell you what I feel inside. And they're like, why are you calling me a girl? I'm a boy. And they start that at age 3, and it persists and it gets worse with puberty. We're like, okay, that kind of person we put on blockers. Now, somebody who arrives for the first time at like they had never had this at all, and then all of a sudden they boom comes out at like age 13, 14. They're like, yeah, I have gender dysphoria. I'm like, okay, let's get you with. We're not probably not going to use when somebody shows up at that state. We're not going to say here's your blockers. We're going to say, let's get you in to see a gender affirming therapist. Let's to help you sort this out. Let's have you come out to people around you. Let's have you take on that. Let's engage in a social transition. If we have somebody who's done a social transition, um, until somebody's done a social transition and a lot of real life experience, we're not going to use any medical therapy because they've been out. If they're like, yes, my teachers know me as Sam, my friends know me as Sam, my parents know me as Sam, I'm much happier as Sam. I've been Sam for 6 months, a year. I'm happy this way. We're like, all right, now we can talk about doing some non-permanent medical interventions while we sort this all out. On the other hand, if you have somebody who's been like, I'm a girl, as soon as I can express my girl or boyness, I've been telling you I'm a girl since 3. And I've been a girl 3 all the way up to I start puberty at 10. Um, and then at 10, I'm like, okay, so how are things now? I start developing, and it gets much worse. I'm like, okay, this person's been socially transitioned. Everybody knows them as Sam since they were 3. They've been dressing as a boy since 3. They're getting puberty and it's gotten much worse. That's the kind of person we'd consider, okay, this person has a lot of distress. Let's start puberty blockers and get them with the therapist to make sure this is what they have in mind and see where we are. And even with that, we aren't doing anything permanent to them until they get to be old enough where they can make a future thoughts about themselves and they have enough mental development to get there. Now, for your average person coming in, they just pop up with gender dysphoria. That's much more of a hi therapy. If they have a teenager and their period for the first time, that really distresses them. I might start something like Depo-Provera or birth control or an IUD to say, okay, we can put those periods on pause. We can buy you to take that piece out. We can talk about here. This is where you could buy a binder so you can achieve a more flat looking chest. So you can go out and assume a male social role, come out to your friends, out to your school, present in that role, see how that feels. If you try that out and you're like, ugh, this isn't any better. I was distressed before, now I'm presenting as a boy and I'm still the same distress. I'm like, well, this isn't your problem. Uh, so
So
that's why we're not.
yeah, I guess I think philosophically we're on very different pages because I'm hearing you and
Right.
I'm like, how could you possibly suppress somebody's period when that's a really important part of, we have to, no woman that I know of enjoys her period, like none. I don't know of any woman who's like, yes, I'm having my period. It's a great thing. And
Right.
especially as girls, I remember being mortified. It was a very difficult time because you had to worry about
Mm-hmm.
leaks and you had to worry about cramps. It's
Mm-hmm.
completely not pleasant. So the idea that you would just sort of suppress that when a girl comes in with distress over that, to me, it's like, why not teach them how to um, resolve that distress or accept the fact that they're going to have these feelings, which is typically we try to help people become more comfortable with who they are, become more
Mm-hmm.
comfortable in this body that they're going to inhabit. And I guess my fundamental question is, what is gender? Because to me, when you
Mm-hmm.
describe it, it's based solely on stereotypes.
Well, there's a internal experience of my gender identity, who I perceive myself to be.
What does that
I
mean, though?
feel
I
like a
mean,
boy.
what does that mean, though? What are
It's your internal.
those feelings are based upon what?
It's your internal experience of what you wake up. I'm a boy. I say, okay, I feel like a boy, or I
But
feel
they
like a
feel like
woman.
a
My
boy
internal experience is that. Well,
they
their
feel like a
internal
boy
experience is I
because
am a boy,
they feel like they're a boy
or
because
no,
of
they're
gender stereotypes. Like, do you have boys that wake up who are,
so.
physical boys who want to, play basketball, wear boys' clothes, but still have an internal experience of girl? I mean, to me, this like concept of like it's almost like a spirit, like their spirit is the opposite sex. Is that what you're saying?
So there's yeah, their internal experience of who they are. Most people can identify as a gender by well, another example, sexual attraction. People can say, yeah, I'm attracted to men, I'm attracted to women. It's not necessarily a gender stereotype that I might be attracted to women or I might be attracted to men. I just am. Uh, I'm a boy or I'm a girl. It's not necessarily a gender stereotype. Now, your gender role or what society expects of you and the things you're allowed to do and expected to do, that is very much based on your society and where you live and what you're allowed to do. Your gender identity is something you wake up with. Orientation. There can be some flexibility to it, but for many people, it's like, yeah, I'm exclusively hetero. The idea of having a romantic or physical involvement with somebody of the same gender feels wrong. It's not something I'm interested in. So people can also have the same experience with, I'm a boy, and I wake up with the I'm a boy thoughts. And if the external parts don't match, that's a concern. Now, your gender role, what you
Can I
do,
just interrupt? Because I wonder when you're saying that,
go.
how is that different from anorexia? Because I also suffered from anorexia when I became a teenager, and
Mm-hmm.
a lot of that was because of the curves I was developing that made me extremely uncomfortable. And so, based on what you're saying, it sounds to me like a doctor should have encouraged me to lose weight so that I didn't have those curves that I was uncomfortable with because it was causing me so much distress. And also, based on what you're saying, I'm guessing that you would consider me to be transgender, even though I'm presenting as a woman, because I don't wake up every day feeling like a man or a woman. I don't ever feel like a woman. I just know I am a woman.
So you wake up knowing you are a woman.
Well,
And we don't
I wake up
start,
knowing that's what
and we,
society is telling me that I am based on my
right.
biology. And
Mm-hmm.
I also have gray hair, and I know that based on what society is telling me about color. I know that I am,
Right.
54 based on what society is telling me about age.
Mm-hmm.
I don't feel, I certainly don't feel 54. And I
Mm-hmm.
am surprised every time I look in the mirror and I have gray hair because I still feel really quite young at
Mm-hmm.
heart. And so
Right.
when you talk about these sort of internal feelings, our feelings oftentimes don't match what, what is actual reality.
That is true, and which is why we don't necessarily treat transgender, we treat gender dysphoria. So if somebody is wakes up and I feel like a woman, or I feel I have a more woman female identity or female soul, to put it in your terms, and I have a male body, but it doesn't make me want to kill myself. It doesn't make me want to uh, engage in unwise substance use to try and paper over those feelings, then those are your feelings. That's your experience. That doesn't need to be treated. We don't treat feelings, we treat a level of distress. So if we have somebody who comes in saying, I can't bear to wash my chest because I can't bear to touch myself because this feels so terrible, and I'm very distressed about that, then we're like, okay, we need to get you into the therapist. Um,
Right, which the therapist
and
now will
sometimes it's,
automatically affirm typically instead of asking, like in my case, if I were a kid who walked into a therapist who had been, pounding her vagina with rocks
mm-hmm,
because, I had so much hatred for it. Um,
mm-hmm,
I I mean, to me, that's the same as the breast. I mean, when my breasts were growing, I mean, even now, I sometimes feel
mm-hmm,
uncomfortable with them. It's not because I'm born in the
mm-hmm,
wrong body. It's because of the way men treat me as a result of my breasts. Because
mm-hmm.
it elicits a lot of attention that I'd rather not have, and mine aren't even that big, so I
Mhm.
can't even imagine how that is for women who have large breasts.
Right.
But again, that's distress that I'm feeling about my body, and I know if I had gone into a therapist these days, I mean, my school psychologist didn't say, "You're right, you're Timothy, you're a boy, you should go into the boys' bathroom. We're going to start allowing all the teachers to call you Timothy," because I was very insistent. I was actually quite aggressive about it. Instead, they
Mhm.
identified as saying, this is a kid who's got some pretty significant issues. Let's get them into some therapy to help them to manage these
Mhm.
feelings. And it wasn't easy. I mean, it took a long time, but I
Mhm.
didn't have to damage my body in order to become accepting of it. And it's hard for me to understand how doctors are willing to, this is all about feelings, and we know feelings can
Mhm.
change. Feelings are malleable, and gender
Mhm.
identity changes. Otherwise, I would still be saying I'm a boy. That
Mhm.
identity of mine changed first from being a girl, then to being a boy, and now to
Mhm.
being a woman, based
Mhm.
on the fact that I'm willing to accept that when people say a woman is this and this, I'm willing to say okay, just in the same way that I'm willing to say my hair is gray because this is what we've all agreed upon is gray. I mean, I could insist it's
Mhm.
not gray, um, and insist people call me a blonde, but it wouldn't be true, and I could have a lot of distress about that. I could
Mhm.
have extreme distress about that. I could be suicidal. And I know
Mhm.
that when people are suicidal, they're not able to consent to things because the suicidality, those thoughts actually compromise their ability to consent.
Mhm. Um, so, uh, couple things. So, you said you have a lot of distress about breasts because the way people treat you.
Mhm.
And that goes back to the gender role you're being asked to do in your society is unfair. It's a man's world, and so women are judged by their appearance, and that can be very uncomfortable. But that's very uncomfortable from a gender role perspective,
So how do you eke
and
that
so being
out if a
uncomfortable.
kid comes in, especially a teenage girl? How do you eke that out? Because it's to me, we've seen this exponential. It's
Yeah.
probably even greater than exponential
Hmm.
rise in girls, and we've also seen in our society. I mean, when I was a little kid, girls and women were somewhat sexualized and objectified, but nothing like they are now.
Hmm.
I mean, it is just unbelievable to me
Hmm.
what these kids are having to go through. Is being encouraged really to be sexual from the time they can talk pretty much. And so when a teenage girl comes in and has this distress about her breasts, she can't even look at them. And she says, I don't want to be a girl. I feel like I'm a boy. I am a boy. I am a boy. How do you eke out whether it's because of gender roles or because she has a male spirit?
Well, that's where a talented therapist who's experienced comes
But they
in,
have to
and
affirm in
it is
many
a
states.
slow.
I mean, in many states now, they have to
Um,
affirm that. And so
well,
how do
they.
you get a
Uh,
talented
uh,
therapist?
oh, that's people experience. We have people who work in where I work. We have a number of well, we have a list of therapists in our major metropolitan area that have done this. Um, just have done this and have experience. We have people who, oh, we know this therapist will write your gender dysphoria after meeting you.
Right.
Nobody they ever seen has ever been not gender dysphoric. I'm like, okay, that probably isn't the person to send them to.
So you have
We have people
people
like,
who,
I have a lot of concerns about this kid. We have
yeah.
people who have concerns. Um,
So
there's
you honestly believe, though, that there's a
um,
male spirit and a female spirit and that they can be born in their own body?
I believe that is some people's experience. And when you give them, I see people who are very upset, very distressed, um, and it seems to be related to their gender. If we give them the hormones, so their body starts to match up. They are smiling, they are functional, they are very happy with their scruffy high school boy beard. They turn into very functional, happy people
Would
when they were
those same
very
kids
distressed.
become happy if you gave them another kind of hormone? I mean, testosterone is a controlled substance. And as you said, it does have psychiatric effects as well as physical effects. So these kids, it's not surprising to me. I mean, I'm sure if I took some testosterone, I might feel a little more peppy in the morning.
Well, people get. I also see people who get estrogen go the other direction, and they're also very happy and very peppy. Now, would they be happy if we gave them something else? A lot of these people have been SSRI use is super common.
Right.
Antidepressants, anti-anxiety medicines are very commonly used in people transgender because they tend to have emotional problems. The ones whose parents and teachers reject them, say, no, you aren't, you can't be that, they tend to have more emotional distress, more depression, more anxiety. The ones whose parents say, okay, we're not going to give you any hormones the entire time you're in, you're you're a child, we don't think you're old enough, or we're concerned about this, or we're worried about the permanent effects, but we will use Susie, she, her. And if you want to shop your mom's closet and dress in a dress, that's fine. We'll support you in that. Those kids do much better.
So
So
yeah, I
people
mean,
get,
I'm
get, get
thinking about the number of kids who are on antidepressants and anti-anxieties. I know one of
Mhm,
the side effects of antidepressants is a really suppressed libido, and I've often wondered if there's a
mhm.
connection between that because if you take a teenage kid who is depressed and you give them antidepressants, it suppresses their libido, which can be very confusing. I mean, one of the things that helps us to accept our biology is our sex drive. And so if you suppress the libido, it seems like that could actually encourage these feelings of disconnect from their body.
Yes, you can see some decreased libido, and some people complain about that. And if they're complaining about a particular antidepressant, we switch to another one.
Mhm.
On the other hand, people who have major depression tend to have a very poor libido. People who have, severe anxiety tend to have sexual dysfunction to go along with that. And
Mhm.
so, for some of these people with bad depression or bad anxiety, given medicines, they can have that improve because they're like, oh, I
So do
used to
we
like
know
hide
much
myself in
about
my
the
room and not talk to
interaction?
anybody.
Do we know much about the interaction of antidepressants and cross-sex hormones? Because that's something that I have not seen any research
Oh,
on, and I'm really curious to know
golly.
because so many of these kids are already medicated on something.
Mhm. Um, Short answer, no.
Mm.
We don't. There's not in the studies haven't been done.
Right.
There aren't great studies. I mean, as you know, as you've done your research, there's not a ton of longitudinal studies
Yeah.
looking at how these things happen. There is a one of my co-investors in the military, Dave Klein, has put out an editorial in the Transgender Journal. Also, he has research where the people who get on blockers, um, most progress forward to get them, but 3.5% at least say no, never mind, and that's of the people who uh, present as transgender, have gender dysphoria with puberty, get on blockers. About 3.5% of them say, yeah, never mind. They come off the blockers and they progress down their original pathway.
3.5%
There's
is
many other
tiny.
people
Yeah, it's really tiny. So it's not
of people who
necessarily a
had
pause.
well, it is a pause for those 3.5% that were like going around the wrong pathway. But most of these kids are people who have been presenting as of their gender for years before puberty, and then when they
Right.
hit puberty, they present that way again. Now, people who pop up at puberty generally have that pop up. They struggle with it internally for a year or two, then they come out. Their parents adjust to it, then they come in and see us. Um, and so many of those people never make it over onto puberty blockers. The people on puberty blockers are people who've had like gender dysphoria, gender nonconforming behavior before puberty. It got worse at puberty. So that's a select group of
Right, which
people.
would have been me.
But
I have, that definitely would have applied to me.
and so you might have been one of the 3.5% where they get into therapy and they say, oh, never mind, and they send you down the other pathway. If somebody is in therapy and they are able to address their gender dysphoria and they feel better about their body with just therapy, then they don't need medical intervention.
Are you
What
in
they
a
need
state where
is the
there is a
therapist.
ban though? Because I know in Utah, I mean, the reason I got into this is because the state of Utah was trying to ban the very therapy that helped me sort of first manage and then resolve my transgender identity. And so now in many states, doctors are very hesitant to explore those kind of underlying issues to suggest, there might have been an assault, there might be internalized homophobia, there might be autism to explain all this. And I think therapists that I've talked to, at least, are hesitant to explore those underlying issues because of this legislation.
That has not been my experience with the therapists here. There's concern. The American Academy of Pediatrics and the American Psychological Association says gender conversion therapy, like therapies that are designed typically, a lot of the research was done in people who were gay, who you're trying
Right.
to make
Yeah,
take therapy
I
to
saw
make
no
somebody
studies based on
who's
people with transgender identities. It was, all the studies that I've seen are based on gay, which is very
right.
different. I mean, and also kind of, suggesting that, these kind of brutal interventions such as electroshock and, ice cube treatments are akin to talk therapy. It's like all this is
Right.
getting kind of messed up. And so, of course, we want to not have kids be electrocuted, but it's gotten to the point where a lot of
Right.
therapists that I talk to, they are afraid to examine underlying issues because the bans in many places cover thoughts, feelings, and beliefs associated with gender identity, which is basically, I mean,
Right.
thoughts, feelings, and beliefs is pretty much everything that allows a person to
Yes.
explore their gender identity.
On the other hand, you can also explore things like trauma. Um, that's for trauma. That's not gender identity. That's trauma. If the
Right.
trauma is related to that, you can go there. Um, the state I'm in, Missouri, the laws, there's legislators are trying to pass laws that say any kind of gender affirming therapy in childhood is child abuse. So
Mhm.
they'll prosecute any physician who provides any kind of medical therapy to to
A
to anyone under the
child
age of
to a
18,
minor, right?
which a minor, which seems like going the wrong, doesn't seem super helpful because we know that when you provide the gender people who have gender affirming therapy, their depression, their suicidality, their problems get better with with gender affirming therapy. Um,
Can I just ask you a question? Because this kind of has me intrigued.
yeah.
So assuming
Hmm.
that law passes and you're no longer able to do
Hmm.
medical interventions with these kids, what would you do instead?
If we were no longer allowed to do medical interventions, well, right now we go against that because we know that providing that to people who are have dysphoria, that's bad enough
But
in
just
the
saying, if
absence of
this
their other
law
medical
passed,
problems.
would you,
But if they
and like you
did, if
couldn't, so
I
what would
would
you
still
do
do things
instead?
like birth, I'd still do things like birth control to suppress periods. We'd still do talk therapy. I might tell them about their options, where they can go, other places they can go to get the kind of therapy they deserve, medical therapy they desire, if that is what they need to address their gender dysphoria. And that's certainly not true in all cases because we have a lot of people who don't. Uh, they don't need it. They don't want it. I mean, they're like, okay,
How
yeah,
do
I
you
feel that I
how do
have
you
a.
eke that out? Like, how would you like if a kid comes in, how do you eke out the kid who absolutely, in your view, needs this versus a kid who can get along without it?
Um, well, I would. So from initially, I would say, so how much you, how out are you? The more out they are to their peers, the more they've said, yeah, I'm a boy, please use Sam. If they've gone to their school, said, yes, I need to figure out my bathroom issues. I need you to change my name in the grade books. I'm presenting with short hair, male clothing. I wear my binder every day. I take my binder off when I'm sick and when I'm sick, when I sleep, or when I shower. Other than that, I'm gonna have a flat chest. And this has been going on for a couple of years, and I seem very happy this way. They're like, okay, I'm very happy this way, but I still can't get in the shower. I still am very distressed by this, and this. I'm like, okay, that person is probably more likely to need hormones or need some sort of medical intervention, as opposed to somebody who says, yeah, I wear my binder and I'm happy.
So what
I
level
usually
of
don't see
distress
the.
do you feel like kids can handle? Because I think a lot of this movement comes from the idea that distress is a bad thing, and that we should make sure that kids are happy. And yet, based on, I mean, my life experience, I've learned a lot from times when I have had a lot of distress in my life. Sometimes it's pretty awful and not fun. But I feel like one of the sort of the motivators in this is to alleviate distress. And the more a kid comes in with distress, the more we want to help them. And of course, as a mom, I hate to see kids who are distressed. I'm a very empathetic person. I don't want to see
Mhm.
anybody who's distressed. But at the same time, it seems like the whole motivation here is to minimize distress rather than to help kids um, cope.
um, yes, there is a tendency to overly shelter children from in my opinion, again, just this is not
Yeah,
pediatrics, this is just my opinion.
right.
But I think there is an element of sheltering people a little bit too much from distress. Life is distressful.
Mhm.
Life is distressing. Sometimes
Unfortunately,
things aren't
yeah.
going to go
And
your way.
puberty,
Things
oh
are
my
not
gosh,
going to,
puberty. I don't think I mean, if I
it's
meet somebody who would go
distressing.
back to puberty, I will be like, this is an anomaly because I've never met anybody who enjoyed puberty.
Right. And so a lot of that stuff, I mean, learning how to cope with that distress is an important thing. I think the level of distress that I worry about is when it starts to uh, interfere with their activities of daily life. If I have somebody who's like, yeah, I don't wash parts of my body because the feeling of touching them really bugs me, and it's doing it on a regular basis. I have the distress where I just ignore my menstrual period entirely. If that's happening, then I'm like, okay, I'm worried about autism
Yeah.
beyond dysphoria, but it's distress that interferes with your ability to do things. If you're totally socially isolating yourself from everyone else, you don't leave your room, you never talk to anybody, you're failing school, you're you're failing life.
This is a kid
Then
who's
I'm saying,
using,
okay, your level of this is a
yeah.
kid who has really bad distress that's interfering with life. Now, if they're passing school, they have friends, they're talking to people, they're living their life, but they're distressed about this stuff. I'm like, okay, distress but functional. That I don't need to treat. I need to treat distress plus dysfunction in major factors: so life, so school, home, friends, social environment. If
So
you
you're
can't,
different, I guess, than some of the therapists that I've talked to who are like, yeah, if they say they're trans, which is what I've heard that over and over. Robert Garofella, Johanna Olson Kennedy has just basically said if a kid says they're trans, and they're more than happy to treat them, which to me is just incredibly concerning.
um, I think it is important to hear the words of people using to describe themselves,
Hmm.
and use those terms because it says, I heard you. I understand what you're saying. You say your name is Tom. Okay, I'm going to go out of my way to call you Tom because you told me your name is Tom. I'm going to use the words you to describe yourself.
But what if I came into you and
However,
said, I'm an African American? Are you going to say, well, yep, you can
I'm
be
going to say,
that?
okay, your experience is that you're an African American. I understand you. I hear you saying you're an African American. Let's talk more about what that means to you, what's going on. Because people like to know they're being heard, that you understand what they're saying, but that doesn't mean, being supportive and affirming does not mean giving somebody everything they want.
Right.
It
And that's where I think,
means, it means,
kids we know will, part of our job as adults is to create boundaries for kids. And so, if a kid comes in and
yep,
says, I'm a cat, I'm going to start using the cat litter. As their mother, I'm going to say, well, you can feel like a cat, but you're still going to use the toilet. And to set that
right,
boundary because I don't want them using the kitty box. I don't think that's going to be a healthy behavior for them in the long run. So it's,
right. Yeah. And so it's a matter of hearing what they say. And if somebody says, I'm transgender, like, okay, you feel transgender. Let's talk about what that means to you, what your internal experience is, and then we can piece those things together and saying, okay, does uh, what else happened at that same time? Like, oh, I feel transgender, but at the same time, I was getting sexually assaulted by my stepbrother,
yeah. Which they may
and
not
I
talk
came to my
about
parents and said I'd prefer to be
incidentally.
with.
Yeah, they may not talk about
They
incidentally
may not
because
talk. They may not talk about that
I was
initially, but
scared
you have to.
silly. I mean, it took me until I was in my mid-20s to really process the
Right.
assault that happened to me, and I had to talk to my brother about it because he was there.
Mm-hmm.
They actually,
Mm-hmm.
held a knife to him and told me that if I didn't
Mm-hmm.
calm
Right.
down. So
Right.
it was one of those things that, it was in the background, but I did not come out and talk about it because I was disgusted with myself,
Mm-hmm.
in all honesty. I thought it was my fault. I was
Right.
disgusted. And I also had this
Mm-hmm.
fear that they would come back and hurt me. And so a lot of times children
Right.
aren't really going to be open about these kind of traumas.
Yes. And that's again why you get somebody in. If you, but kids who have underlying trauma or underlying issues present in a little bit different way than kids that don't. And so the more they present like there's something different with you, you are not a classic gender dysphoria patient that I see. You're like, you're a little off, or you're a little not what I expect, or which is why you need an experienced provider who's seen a bunch and seen a bunch of people going through gender issues with gender, and you're like, okay, you're kind of center of the mass classic textbook case. You're over here on the side. I need to be a lot more careful and cautious about what I do with you. And I'm much more likely to ensure that you're engaged with one of the therapists that I know and trust that doesn't say everything's gender dysphoria. And so I'm much more likely to say, here's some lovely therapists in your area that you can work with. Once you've worked with that therapist for a little while, we're feeling a little more comfortable, and you've sorted out what your concerns are, what your level of dysphoria is about, what bothers you, or how can we help you? What do you feel you need? Once you've worked through those things with a talented therapist that doesn't have any permanent side effects, then we can say, okay, now we can feel a little better about going forward with this, because we understand that we've addressed the underlying issues. But part of that is definitely sorting through their internal experience, the way they got to where they are, their description of their internal state, because you have people presenting in different flavors, and the less clear, the more like, wow, there's other stuff going on that I'm
I
not
was
being
I
told
was so
about, or
insistent. I mean, I was like, "I'm a boy."
right,
It wasn't
yeah,
any like, "I feel
and
like a boy." It was, "I am a
mhm,
boy. I'm gonna behave like the boys. I'm gonna be treated like the boys." And
mhm,
anybody who didn't do that, I was gonna lash out at. And so
right,
I do feel like there's so much nuance in all of this. And
mhm,
I appreciate your time and your willingness to engage in this
mhm,
discussion, because we've veered way off topic here. And I realized that originally we were just going to talk about your study, but I find these issues really important, and you really,
mhm,
I appreciate your candor, and willingness to sort of explore these issues, because I do think that there are a lot of doctors who are just so in that camp of, if a kid comes in and says they're transgender, and treats them as that. There is no questioning. There's a push now to remove gatekeeping. And a lot of, I know Planned Parenthood now uses an informed consent model, and a lot of clinics now are suggesting that's appropriate, even though they're dealing with kids. The one thing that I wondered is, you talk about sort of a classic presentation, and you talk about,
uh-huh,
the kid like me who is like, I am a boy, I'm a boy, I'm a boy, from the time they're a little kid until they hit puberty, versus,
mhm,
the teenage girl who comes in who's just hitting puberty and says, I'm a boy. Those are two very different presentations. And yet, from what I'm
mhm.
seeing, they are both treated, they're both completely accepted as if they're transgender without any questions asked, in many, many cases. And so, in which of those cases would you say, which of those is typical? Which of those is sort of the classic, that you would feel comfortable treating, versus one that you feel like you should explore a little bit more?
The kind of classic case I hear is, so when did you start having concerns? Well, when I was a little kid, I had a strong preference for I had a strong preference for female activities. I wanted to play with the girls. I wanted to be Barbie. I wanted to wear dresses. I wore my hair long. I hit puberty. Um, I hit puberty. My testicles and my penis started to grow. I found that very bothersome. Um, I asked mommy, "Can you send?" I had a patient that they asked their mom, "Can you send me back to God so you can give me my penis?" And I'm like, okay, that probably not going away, or may not be. We'll see. But they get to puberty, they're like, "Yes, this got much worse." Or I see a lot of people that, "Yeah, I got breasts." I'm like, okay, well, I guess I have breasts. I'm gonna have to work with this. And then I tried to be
So,
ultra femme for a year. I'm
so
like, oh
they're,
no, that didn't work at all.
but if they're on puberty
There's a
blockers, then they're not
progression.
going
Oh,
to develop, and so they don't have that sense of.
there's yes, that is the downside of puberty blockers. On the other hand, if you have somebody, I feel better about puberty blockers if I have somebody who's been presenting this way, has been very insistent, the last 5, 6, 7 years. Their parents are on board. They seem very happy with their role, with the gender role they're playing in. Their internal state matches their gender presentation, and the gender role they're playing, or the gender role they're taking or assuming or living in. then I'm like, okay, we're gonna start. They get hit puberty. They have those hormones. They get some changes that's super distressing for them, and that small changes are enough to make them like, terrible. We can get them into see a then we can get them to see a therapist to explore that a little bit more, just to make sure there's nothing else going on, like trauma, depression.
Right.
Um, you know,
And it's funny because you know what helped
then
me a lot was smoking pot, which
right.
that helped me to separate from my
Hmm.
body. It actually increased the disassociation feelings
Right.
so that I felt like
Right.
I wasn't my body. Um, and yet I would feel very uncomfortable with suggesting that 9, 10, 11-year-olds smoke pot. And yet that's what I did because it was accessible to me. I had, there was pot in my house.
Right.
And it really helped with those feelings because I just felt kind of disembodied. And so, are
Oh,
there other medications that might help these kids? And are we willing to give kids something like, let them smoke pot if it makes them feel better, or how give them some heroin if it makes them feel better? Like, at what point do you say this intervention maybe isn't going to be helpful in the long run because
what?
it's going to
Uh,
discourage them from processing what they need to process?
at what point do I say marijuana or heroin's not the right thing to do, or do I say that puberty
Or
blockers
whatever
are not the right thing to
intervention. I
do?
mean, whatever intervention. I mean, to me, puberty blockers is sort of it's very similar to the way I use pot. It sort of allows a kid to sort of pretend like, you know, they're not really what they are. So it sort of allows this increased disassociation. I think that disassociation is something that we've seen is problematic in psychiatric fields. They tend not to encourage disassociation. And
Mhm.
yet I feel like puberty blockers and these other treatments actually encourage the child or the young adult to feel that, to accept that dissociation and to embrace it.
Mhm. Yes. On the other hand, if they have severe distress and it's causing problems with function with their pubertal development, allowing that pubertal development to continue along and continue to cause them distress, which prevents them from functioning in the rest of their life or to engage with any therapy about how they're feeling, that's also problematic. So it's a matter of balancing. I mean, so could going through these experiences and having increasing distress benefit them? Um, yeah, but if they're having that and they're having that distress and they're able to move forward and engage in therapy and engage in their life, again, they're functional, then they don't necessarily need that intervention. It's the people who are um, not able to function or having a lot of functional impairment associated with these parts developing, then we say, okay, we need to and for the first set, okay, you're having this development, you're distressed about it, but you're still functional, you're passing your classes, you have friends, you're functioning in your class and society and your family. Then we say, okay, parents, you just need to be supportive. Pronouns, name, gender. Let them play the gender. Let them have the gender role they want. Let them try out that particular pathway to see how it works out for them, and just experience with them will let you know, do they need to continue down that pathway, or like, oh, I thought this was my fantasy of this in my head was that it was going to be great. The reality of this is not nearly what I thought, and it doesn't fix my problem.
Well,
And we're
and
like,
what
okay,
I've
we
heard
stop.
is kids who
And,
do
but
this
so
is they have this idea that they're going to do this social thing, and then they're like, well, that didn't work, so now I want testosterone. Well, that didn't work, so now I want top surgery. Well, that didn't work, so now I want phalloplasty. And then they're left with nothing else to pursue, and yet they still
right,
have the same distress.
yes, but what you're really looking for, if somebody says, "Yeah, that didn't help me at all,"
Yeah.
then the solution is not doing more. Is the solution is, are you sure you're on the right path? If they're like, "Oh yeah, I went down the name social transition, and it made my day. Every time I went to a restaurant and somebody said, 'Well, do you want a menu? Would you like a drink, sir?' They're like, 'Yes, I would like a drink. I would like a manly drink,'
So now it's
because
about the feeling happy again.
I mean, they're happy. So they're happy. They're in a gender role. They're being treated as male, and they're being treated by society in a way that matches up with their internal feelings about themselves. They're like, yeah, because they're part of society. So there's your gender identity, and with that gender identity, you have certain expectations for how the world is going to treat you. When
Right.
the
And how is that
world and your
different
gender
from
role.
How is that different
Well, because
from
I
me
have,
being an older woman and wanting to be treated like a, 26-year-old? Because that's kind of how I still feel. I mean, I really, when I look in the mirror, I have to tell you, I have like cognitive dissonance because the mirror says
mhm,
I'm a middle-aged woman or older, and yet
mhm,
internally I do not feel that way. I feel young. I do goofy things. I act like a much younger person. My kids are sometimes even embarrassed by me because of this.
uh-huh,
And yet, I don't think changing my birth certificate is an option. Maybe it should be. What do you think?
right. So I think that women do experience that cognitive dissonance as the changes they see on their face and in their body don't match up with what they experience internally. And many of those women choose to go to plastic surgeons,
Mhm.
where they make their external appearance conform with their internal appearance, with their internal thoughts of themselves, so that cognitive dissonance goes away.
So
So you're like,
that's an
I'm supposed,
elective
I'm
cosmetic treatment. Not
that's
necessary,
something.
but it's a something they choose to do.
So depends on the person. If you have somebody like I was in the military, if somebody has 60, 70% facial burns and their face is a massive scar tissue, it may be beneficial to them to have surgery to give them a more normal appearance. And so we treat that as elective because your average woman who has cognitive dissonance of the fact that, oh, my hair is gray and my hair is gray and my
I'm
mental thoughts
sagging
is
in
that I have
places I
long
don't.
flowing blonde locks.
Yeah.
Right. And so all that stuff, they have cognitive dissonance about that and they're bothered by it, but they don't want to kill themselves over it.
I don't
Um,
know. Like, I
or
mean,
they
I
they
think
want to
if
be
somebody
or they want
convinced
to be
me of
dead.
that,
So if
yeah.
people
I mean, so if I did want
if
to kill
somebody
myself
convince
about that, then do you think that insurance companies should pay for those medical treatments for me if I had so much distress that I wanted to kill myself?
I think that insurance companies can pay for things like an implant. So if you have breast cancer and you have a breast taken off, they're going to give you they can have something done to produce a more uh, symmetric appearance to the chest
Right.
with
But if
that.
I were
For things
suicidal
like
and
Botox
about
to
my
address. So if you were suicidal about normal aging processes in a person who is of your gender and the gender that matches your internal state, then you need therapy to help you deal with the fact that you're aging. If you want
right.
to dye your hair, if you want to be blonde, you can be blonde
Right. But what
temporarily.
about, I mean, I've
So I don't
often
think
wondered
I.
if I identified as a man, I could get a breast augmentation
Mhm.
operation. But because I'm a woman, I'm not offered that cosmetic intervention, even if my distress is the same as a man who wants breasts. I mean, that's where I feel like this is
Well,
very problematic because, I know my insurance actually pays for cosmetic medical treatments
mhm.
for men who want to appear more feminine, but they will not pay for those treatments for me if I want to appear more feminine, even if we have the same level
um,
of distress, which seems sexist.
because
It seems very sexist.
they put it in a different category.
Hmm.
Um, One of the reasons is purely probably for financial reasons that the insurance company says, wow, there's a lot more women who might want their breasts changed than transgender women in the world. Also, um, there are, so if you have somebody with the same level of distress, if you have a psychiatrist or a therapist, you convince them that that is your level of distress and specifically about that, they might be able to make a case to the insurance company they should make an exception for you. It would be unusual, but they could do it. But we put transgender in a different category because we have. Um,
Because, well,
there's
and that's the
a,
interesting
a,
thing, that
a,
that
a lot
internal
a lot
sense
of
of
things.
sex is somehow prioritized over, there are so many women who feel fat. Even if they're not,
Mhm,
they feel fat. Their internal identity is of a fat
mhm,
person. I
right.
actually have problems when I'm shopping because I buy clothes that tend to be way too big because I have that disconnect.
Mhm,
And
mhm,
again, I think this is pretty common with people who have trauma. They have these disconnects from their bodies that makes it a little bit harder for them to feel that
Hmm.
integration that's important. But
Right.
there are, I mean, I would say every woman I've ever talked to would, identify as overweight. And that's an
Hmm.
identity. They wake up every day feeling that way. They look in the mirror and they feel
Hmm.
that way. And yet our insurance companies will
Hmm.
not pay for them to have cosmetic interventions to help alleviate that. So it does feel like this is one identity that is prioritized over all these other identities that we have and all these other feelings of dysphoria that we can have related to different things.
Yes, although insurance companies will pay for somebody who has a problem with overweight if it gets to the point where they have functional problems. So if
Even
you're
if they
having
don't have
medical
mental distress
complications,
about it, right? So they could be someone who's
even if they
not
don't have mental stress with it,
mentally distressed, and so it's again it's a different category. If I
right?
had the same level of distress about
And
being overweight as some other person had about their being in their sex body, um they're
mhm,
not treated the same. The gender identity for some reason is prioritized over all these other identities that we can have.
it is now. It used to be that it was treated as a mental disorder, purely as a mental disorder, and people were locked up or put in jail for it. And so society is making a choice that
I don't
this
know, were
is
people put in jail
a
for having I mean, I think that might
people are put in jail for
for
people
cross-dressing
are put in
perhaps, but
people are
not for
put,
having the identity.
well, nobody can see your identity. You
Exactly.
see your identity.
Right, exactly.
But if you act on that identity, people got locked up. I mean, the Stonewall riots. There's the Stonewall riots in New York. The cops coming by the gay bars and hassling all the people in the gay bars, and rousting them, arresting people on a routine basis. And at one point in the 70s, there was a bar called the Stonewall Inn, and the cops come by to hassle everybody and arrest them.
That was
And two of the
because
first
of
people start the riots.
homosexuality, right? Yeah, and I think that that's
Well,
horrendous. That's
the
based
two of
on
the two, but two,
being gay and
but the
having
two people, but
alternative those people, most of them identified as gay, not as the opposite sex.
right. But the two of them are two of the people that led that entire riot were two transgender women who were being hassled for being transgender.
Which is different. Again, I think that
Um, I
I
I
think
put that into a similar
they're
place. I
not
say
being arrested for their identity. They're being arrested for the way they act upon that.
yes. I mean, but the police don't arrest people. Didn't arrest people for being gay either. They arrested gay men for having sex with men.
Right,
They arrested gay
exactly.
women for having
Yeah,
sex with women. So
yeah.
that's also acting on your. So that's just acting on your sexual orientation.
But they
So
also arrested
there's
Black people oftentimes. There was horrible discrimination against Black people. So if a Black person came into a doctor and wanted their skin whitened, that's not covered by medical insurance. That's not something that we advocate for. And yet there are processes that can do that. It is possible for people to change their skin color.
yes, it is, but it's not paid for. And again, we treat it differently. We treat many things differently. It's uh, it's certainly unfair. It's unfair for certain things, and that's just a um, it is. I mean, there's many things that are confusing, or don't seem right, or don't seem fair.
Yeah.
There are we take the people where we find them. Is it possible that some people who come with gender dysphoria, if they got enough therapy and enough experience, their gender dysphoria would go away? Yes. But we know this in the right patient, this other intervention works also works very reliably and allows them to continue on with having a normal, healthy, productive life. Many of our patients, they don't want to be the flag waver for this. They
Right. And
want,
that's
I want
actually
to
it's
disappear into
yeah,
I want to disappear into the crowd with
yeah,
the guys. I want to be like,
exactly.
I
Yeah.
get
And that's
treatment, I convert,
yeah.
boom, guy,
Yeah.
happy, productive citizen.
And that's something that I
And
feel
that's
like has been
kind
really kind of sad about the visibility of some of these issues, because there are people, they just want to live their lives. They just want to go about their lives. And I
Right.
have a lot of compassion for them. But when we get back to the sporting events and locker rooms and such,
Yes.
so the fact that,
Yes.
here I am, I was actually, the sexual assault that I had occurred in a bathroom. It was a public bathroom.
Right.
And, I was at an empty park. And
Right.
so I already have some anxiety going into bathrooms. And now, because of this
Hmm.
movement, fully intact men who are not suppressing their testosterone, who are not taking any
Hmm.
kinds of hormones, are now asserting the right to female spaces, are now saying that they should be able to compete in female sports. And so it's like their identity is privileged over my identity, over me, over my biology, over me as a person. We're making these exceptions, and so that's where I think it is problematic to say, any teenage kid, any teenage boy who wants to say they're a boy gets to be treated like a boy, gets to go into the girls' bath, or as a girl, gets to go into the girls' bathrooms, gets to compete as girls. Um, their gender identity is now being privileged over my biology.
Yes, you are balancing the effect on that individual, the benefits for that individual against the negative effects of the other people in that space.
Right.
Um, the reality is that the person who's at the greatest risk for being assaulted in that bathroom is the transgender woman
In a woman's bathroom?
in a women's bathroom. If
Is
you're in the,
trans-
if you're in the, if you're in the,
what about in a men's bathroom? If the man who identifies as transgender goes into a men's bathroom, why is it
if they're
are
if they're
supposed
pre- if the transgender woman who's dressed as a woman goes into the men's bathroom, they also are in a space where they don't belong. So people who
right?
note that will be at greater risk. So that the
So
person who's going
why
to get
is it
physically
that if
assaulted.
they're uncomfortable being in a men's bathroom, but if I because of the men in there, but if I'm a
Mhm.
woman who's uncomfortable with a man in my bathroom, then my feelings aren't as important as the man who's uncomfortable going into the men's bathroom.
well, well, so if somebody is presenting in a full female role, they come in, dress, heels, long hair, makeup, and they go into the bathroom stall and close the door behind them.
You know what? We do
Then
a lot more
what?
than just pee. I was actually in a bathroom, and because the stalls were taken up, I was undressing, and
Mhm.
um, a man walked in who was in a dress and lipstick, and it was and I have to tell you, as a woman, first of all, I knew immediately it was a man, and second
Mhm.
of all, he did not act like the women. He actually was ogling me. Women don't do that to each other.
So if you have somebody in a bathroom who's ogling other people, regardless of the gender that person is or what they happen to have in their pants, that person is engaging in socially inappropriate behavior, and they
Definitely.
need to be, and they need to be, and their socially inappropriate behavior needs to be addressed.
Right. And that's where I
The
guess
socially appropriate.
why is that put on women though? Because already as we've talked about this, we've talked about how, they created women's sports because women needed those opportunities. They
Right.
created women's bathrooms because historically women weren't able to go out in public because they didn't have restrooms available to
Mhm.
them. So women historically
Right.
have had to fight for these opportunities. And now, rather than, again, I would say, why not push back on the men and say, you need to start being accepting of guys in dresses when they come into your bathroom, rather than telling women once again that you have to accommodate men.
Yes, and because it's less of a concern for everybody when the transgender man goes into the men's bathroom. So
Because
if
they're less likely to
you
be
have a woman
victimized.
coming,
Yeah. I mean, it has to do with,
because
they're less likely to be victimized. Whereas,
they,
and that's where I guess, that's where I think there's this like,
at the
singular conundrum.
transgender individuals, well, transgender individuals in either space are at risk for being physically assaulted. just because they're not there
Actually,
and people have a negative reaction.
everybody's at risk for being physically assaulted.
Everyone is at risk for being
Everybody
physically
is.
assaulted. The
Women are
people
much more at risk
transgender.
of being women are much more at risk of being
Oh,
physically
absolutely.
assaulted by men,
The,
by
the,
biological men. I
the,
mean, that's
yes, women
very
by
rarely are
far are
men
much
assaulted
more
by,
likely to be assaulted.
yeah. And so this is where I
Yes,
guess we come
it's
back into
so.
this, what your research did, and where I think there's this
Yeah.
like tension, because
Uh-huh.
fundamentally I'm against people taking, and a lot of people are concerned about children, especially being encouraged to medicalize, when there's such a high
Hmm.
rate of desistance of kids who don't medicalize. And so to me, I feel like, those medical interventions should be held off as long as possible, because they do have, I mean, there are going to be, I mean, I have no doubt that once we start doing longitudinal studies, we're going to find out that these kids are not faring as well physically as their counterparts. I think we've already got some evidence to that, but we need some really good longitudinal studies to make those cases. Um, and again, we're pushing this idea that, that the transition is appropriate, when we could be saying, if you want to be gender nonconforming, that's okay. Um, and I just feel like we get back to this, like those boys in Connecticut who competed against the girl, if they had been told that they didn't have to medically transition in order to compete, would they have medically transitioned? Like, I just
They
feel like there's so many like nuances to this that we haven't explored as a society. And those girls undoubtedly, were likely to have won if they weren't competing against biological males who hadn't transitioned medically.
Yes, and so those boys who are in Connecticut, they were allowed to compete without medically transitioning. They did a
Right.
social transition. They started competing, and they started medically transitioning anyway. So it's not they're
But
coming
what
over
if
to
they
compete. They
hadn't?
medically
What
transitioned.
if they hadn't? Would you still?
I I think well, if they're not medically, my thoughts, if they're not medically transitioning, it's unfair for them to be involved in women's sports. Period. And so it's it's unfair to the natal women who were there for them to be competing because they have an advantage. And I feel that medical and hormonal therapy negates that, decreases that, lessens that advantage they have, and makes it fair for them to compete. And so you're balancing the benefits to them
At
of being
some
able to
point.
compete
Do
and
you have any
experience
thoughts
life
about
as
genitalia? Like whether or not they need to, I mean, because that's the other issue is, what happens. I mean, this, you probably know more about this than I do, but because this is an external, process that they're causing their body to go through, um,
Mhm.
theoretically you could have, a man who goes on and off these treatments, and so, and what should their category be, and should we institute like, monthly checks, like, daily checks, weekly checks, yearly checks, for these, to make sure they're staying on these, medications. If I know you didn't study this, but say these, the men who are identifying as women, had suppressed their hormones, and were taking cross-sex hormones for 2 years, and competed,
Mhm.
and then went off of them. Um,
Mhm.
at what point does their advantage return, and at what point should we say, hey, you're no longer allowed to compete in women's sports?
Well, I think that they should be on suppressive therapy, and they should, 2 years on suppressive therapy to compete. And if you're going to continue to compete, you need to be on suppressive therapy. I mean,
But what if they went
if
off them
you're,
for like 2 years and then wanted to compete again? Like, then would they have to do
um,
another 2 years on the suppressive therapy?
hypothetical, but I think that we've noticed from my studies that the natal women who who got
Right.
testosterone, they were up to the level of men after a year. So I think if you come off thing, your advantages as a man, if your testicles, if you're making testosterone again, your advantages kick in fairly rapidly. and so you rapidly develop an advantage over uh, other people who don't have the advantage of testosterone. I don't think that there's I think that somebody who wants to come on and off is super rare and unlikely to be, and very unlikely to be a high level athlete. Somebody who's coming on and off testosterone like that is probably doping
Okay.
and or cheating to get
Right.
an unfair advantage. And I think
Right.
cheating to get an unfair advantage is not a transgender issue. That's just a cheating issue.
Exactly.
And
And
cheating,
that's where this is
cheating
difficult.
needs to be right. And so
In the same
cheating needs to
way
be
that I think
punished.
that there are
Cheating,
men who are going to say they're transgender to gain access to women's spaces. That's not somebody who identifies as transgender. It's somebody who's taking advantage of um, the
the
transgender issue.
situation.
And that's where this gets really difficult to parse out. And we don't have a litmus test, as you said, because it's a feeling. So there's no way to tell whether someone actually is transgender or whether they're using it to gain an advantage or to perpetrate against women.
Yes. Um, yes, that is a concern. If I, for people who are gaining access to women's spaces like bathrooms, if somebody, shows up outside the bathroom, puts on lipstick, a wig, and a dress, then walks into the bathroom, I'm concerned about them being a predator and they don't belong. If somebody says, "Yeah, I've been presenting as Sheila for the last year. I always dress in women's lipstick, heels, and a wig, and I always present as Sheila, and I always present as a she/her, and I've been doing this for the last year," I'm less concerned that this is an act to gain access to women's spaces. Um, if they're doing all that and they're on hormones, I'm really not concerned. I'm really less concerned. If they're doing all that on hormones and they've had bottom surgery, people are gonna have a hard time figuring out whether that person's a
Right.
woman or not.
Mhm. So do you
Um,
think that at some point
but
there
so
will be a litmus test, like that there will be a way to detect this feeling? Or do you think it will always remain in the realm of feeling something that really isn't testable?
I I do not know the answer to that question. I think lots of people look for the gay gene or the gay brain patterns. But I don't think we know enough about how the brain functions to really say, aha, that person is that person's trans, this person's gay. There are This is purely speculative. No,
Right.
but
Yeah,
there's brain
definitely.
patterns there's brain patterns. There's changes that happen there's changes that
I
happen in
would
brain
doubt that
function.
brain patterns would actually be the test that we would use because we know that brain patterns are malleable. So, if you test me one day and then I, take an intensive course in,
Mhm.
calculus, my brain patterns are potentially going to be different after so I think brain patterns probably aren't going to be where we would be looking for this because it's something other than your thoughts. If it's a feeling, it's not a thought.
True, but there are neurotransmitter patterns. So at puberty, uh, in rats, humans, the brain becomes more sensitive to something called prolactin, which is the same hormone that's involved in bonding, which is also involved in milk production, which is why moms have this intense bonding feeling while breastfeeding. Their brain receptors for that go up during puberty, so they're more sensitive to social cues. They're more sensitive to the people around them and how those people feel. This also matches up with a time when there's a lot of group conformity
Yeah.
and peer pressure and peer behavior. There's also patterns that are responsive to sex hormones. So there's patterns that when sex hormones are exposed, you see this pattern of brain function that happens. And there's also a third pattern where there's patterns that are established before puberty, and they light up more when hit with sex hormones. Purely speculation, but if we find out there's a pattern that's established in the brain function that is a more classically female pattern and it hit by and it's given testosterone, that may be transgender. It's like, oh, I have a pattern that says one thing, I'm getting exposed to the other thing, it doesn't feel right. But that
So it
is
would be really interesting if
way,
that were
way,
the
way,
case,
way,
and we
way. It would
started
be
to like,
it would be super.
yeah,
It'd
I
be
mean, I
super
imagine
interesting.
if we did that, that we
I
would
can't
end up with
prove
a
any of
lot of
that.
gay men who were encouraged to transition and a lot of lesbians to encourage to transition because potentially their brainwaves would be less typical of the sex, and to me that would be a
Right.
tragedy. I would hate to see, I mean, and that's one of my biggest concerns right now, is that we're actually transitioning gays and lesbians, especially gay men. You know, my son was gender nonconforming when he was a little guy. He loved
Hmm.
pink. He loved to wear
Hmm.
dresses.
Right.
He loved Hello
Right.
Kitty. He loved everything associated with
Hmm.
he, you know, we took him out for his fourth birthday party, when he was 4 years old, and he ordered a sundae and he wouldn't eat it because it was too beautiful. I mean, these are very typical,
Hmm.
you know, very
Right.
stereotypical girl behaviors.
Hmm.
Um, I don't know
Right.
yet what his sexual orientation is, because he hasn't really,
Right.
he's not old enough to really exhibit one. But I do know that a lot of,
Hmm.
you know, anecdotally, a lot of gay boys tell me they would have been transitioned because
Hmm.
they had this tendency. And I just think, to me, oh my gosh, haven't gays and lesbians had enough to deal with? Now we have to worry about whether or not little gay boys are going to be told they're actually girls, and whether or not little lesbian girls are told they're actually men.
Right. Which is why before puberty, you don't do anything
Right.
other than tell parents you should support them. If they want to wear dresses, let them wear a dress. They don't want to eat their sundae? Great. You say,
Right.
you're right. That is a super
See, and
beautiful
it's
sundae.
interesting because I didn't
um,
actually let my son wear dresses all the time. I was very clear that he could wear a dress when he
mhm,
was out in the shop or when he was gardening,
right.
because I,
Hmm.
you know, but he could wear pink. He wore pink flowers and Hello Kitty shirts and,
Hmm.
you know, girl boots all the
Right.
time. And it was, you know, um,
Right.
he actually, I think, got a kick out of it. He's one of these kids who liked watching the expressions of other people, and I think he really got a kick out of it. He
Hmm.
like kind of likes playing with people, but
Right.
if you have a boy who is being told by parents, I mean, I have experienced parents who would much rather have a child that presents as a straight child than as a gay child. And so if they're
Mm.
concerned that that child is gay, they might start saying, oh, well, you're actually a girl, because for them, it's a lot more comfortable for them to have that child present as straight than as gay.
And that's a parenting problem as
It
opposed to a
is.
transgender problem.
But how do you
Um,
eke that out in therapy? Because you don't do therapy with the parents typically.
well, for pubertal kids, you get the parents involved a lot because because a lot of times for your gender nonconforming kid, the kid's happy. I mean, the kid's like, yeah, I don't have a problem here. It's my parents that are acting weird. And so the therapy is aimed much more at the parents, like making the parents feel
To accept
more
that
comfortable with
transition.
their kids, to
But
accept what
what
their
if
kid's
it's the
doing,
parent who's
be
encouraged the
supportive.
kid to be happy about looking as if they're presenting as the opposite sex?
Then you need to address that with parenting,
Yeah.
because it's again, that's a parent problem as opposed to a kid problem. And so the parent is the person with distress in the situation, and who's not functioning properly,
So do you at
which
all,
is,
like if a
you know,
kid comes in with, you know, maybe a 7-year-old kid comes in and the parents are like, yep, they're transgender. Do you ever try to like explore whether or not the parents have some other something else going on that is influencing the kid's behavior? Because we know parents have an
uh,
incredible, I mean,
oh yeah,
parents have so much power over what their kids think and feel.
right. So yeah, I always explore that. I'm like, why do you think that? Tell me about how you experience that. And if I hear things like, yeah, at age 3, he refused to, he re, no, sorry, at age 3, she refused to ever wear a dress again. Pink was anathema, and she's like, I'm gonna wear black until they come up with a darker color. I always need to dress in boy clothes. I'm doing stereotypical boy things.
Yeah.
Um, and they insisted I call them Sam. I'm like, okay, this has been this way the entire time. I'm like, okay, this feels like a responsive parent. Um, you know, um, so then you just kind of feel how the parents talking about it. If the parents seem distressed or there seems to be a disconnect there, then you get them into therapy, and the therapist has talked to them for a long time, and the therapist hopefully can get at what the parents are thinking, what the parents are believing. A lot of times, if you have really bad homophobia and but I find that many parents have more of a their transphobia is worse than their homophobia at this point.
Well,
but other people have different experiences.
right, and that might be because you wouldn't know if a parent has homophobic feelings if their kid's presenting as trans because their parent would be affirming of that. So it gets very complicated.
Right.
It really is a very complicated issue. I'm glad
Yes.
you're doing research because I think that one of the things that I'm seeing
Mhm.
is, there really is not good research. As I mentioned when we were talking about suicide, I'm seeing, most research is based
Mhm.
on, retrospective self-reporting, which we know isn't particularly effective. And so hopefully we will be seeing
Yep.
some longitudinal research. One of the things that, when I was a kid, I participated in Judith Wallerstein's research about divorce, children's of divorce when I was a kid.
Mhm.
And, I think that was the first longitudinal study that had ever been done about the effects of divorce. And it was quite groundbreaking. And a lot of people rejected it because it came out with, the results that divorce is really hard on kids, much harder than they had thought it
Mhm.
was. So I feel like we need those studies where we track these kids over the long term. Unfortunately, the one study that I've seen in Sweden that was longitudinal, the outcomes were so terrible. The increase in suicidality was 19% in those who had transitioned. And so when I see that kind of result,
Okay.
it is very concerning to me that, within the first couple of years, they seem to be doing pretty well. The longer it goes, the higher the suicidality rate goes until it's about 19% at about 20 years out. And so to me, that's a big concern that we might be initially helping kids get through some difficulties, but in the long term, if the suicide rates end up being higher than they would otherwise be, then we really need to re-examine our approach.
Okay. I I hadn't seen that extra study you're quoting with the
Oh, I can
suicidality
send
of
it to you.
19%.
Yeah, I'll send it to you because I
We'll,
think it's a really
we'll
important
trade
study.
studies.
Yeah, we'll trade studies. That would be good. And
Studies.
again, that was the reason that was such a good study is because it was done in Sweden, where they have access to all the
Mhm.
medical records of everybody,
Right.
able to track, not just self-perceived feelings or self-reporting or,
Mhm.
retrospective things. It was actually, longitudinal and they have all those records right there because Sweden is socialized.
Mhm.
So it was a very powerful
Yep.
study. And again, we don't have anything like that in the US. It would be hard to do that. I know that there's a
Right.
lot of lost outcome in the studies that we're seeing right now where a lot of the subjects are actually dropping out. So we don't really know what's happening in those cases.
Yes.
Yeah. So we
But
need good.
longitudinal studies are, we need good research, and longitudinal studies are just really hard. Keeping
Yeah,
track
they're
of people,
expensive too. I
they
mean,
move, it's
yeah,
expensive.
yeah,
And there's enough distress amongst uh, politicians that it's sometimes hard to get studies done. And there's a lot of times, no matter what your study says, um, there's somebody going to be upset about it. If you do a study that says, "Oh, I found the gay gene," like, "Oh, so my gayness isn't enough for you because I'm negative for the gay gene. I'm still
right.
gay." I'm like, that's not what I'm saying.
Right. Yeah, it is. It's problematic
Also,
and
people are
everybody
like,
can spin. I mean, it's possible to, as we know, you can spin pretty much any statistic how you want it to. And in this case, we have a lot of, interest in this. I know, big pharma is making a
"Mhm.
ton of money off of this. Once a kid is on it's, Lupron is crazy expensive. One of the
Yeah,
things
yeah,
that I've seen with
puberty blockers
pharmaceutical.
are ridiculously
Yeah,
expensive."
they're ridiculous. And one of the things that concerned me that really kind of pricked up my concern about Lupron specifically is that I was taking Humira, which is from AbbVie, and I was
Mhm.
just shocked at
Right.
how much they pushed it. I was getting like things in the mail from them. They assigned me an ambassador to call me all the time. They sent me little,
Mhm.
cool little things. They had all this affirming
Mhm.
materials. They even sent me a sharps container that had little like happy messages on that. And I was like, this is
Mhm.
marketing. This is insane. And that's another very expensive
Mhm.
medication. And I just thought, what is going on that a pharmaceutical company is pushing, is marketing, is reinforcing you to take this medication to such a degree. My feeling is if it works that well, I'm going to notice it and I'm going to be happy with it. I don't need all this like all these strokes, all these encouragement to take it, all this affirmation is what it felt like. I ended up deciding I didn't want to take it anymore because I was so uncomfortable with the marketing of
Mhm.
it and with the way they were constantly trying to make me feel good about being on this
Right.
medication.
Well, part of that is that they used to market to doctors, and
Right.
then the doctor said, this seems bad. And so there's restrictions on the marketing directly to doctors. But they found out, hey, we could market directly to patients,
Uh,
and patients will come in and ask for these medicines, which is why you see TV commercials saying, ask your doctor if blah, blah, blah is right for you. And your doctor's like, I don't want to fight with this patient. Sure.
yeah.
Blah,
Yep.
blah. I don't think it's any better for you, but it's more expensive. Whatever.
If you're gonna, well,
Whatever
and
makes
there's
you
the
happy.
placebo effect. If they really want it, if they're going to feel good about it, it might actually help.
Yes, it's more likely that if the patient believes it's going to help them, it's much more helpful. And so
Right.
that, so they said they thought, wow, we can market directly to patients. Then patients will come in demanding this stuff, and then our thing is our product gets sold.
Right. Yes. And then
So
they'll talk
yes, there
about it
is
because
some.
most people that I've talked to are quite happy about all these things that they're getting in the mail, and
Right,
having a special Humira advisor that they can call
right,
anytime, day or night to talk to. And most people enjoyed that. I didn't. I found it
right,
really,
yes,
I really did not like it. But again, it's a way of,
right,
if I was so happy with it, then I might tell my friend who's struggling with some issues, hey, try Humira. It's
hmm,
wonderful. So I think you're right as
right,
far as the marketing goes, which is something that
yeah,
we
it's
don't have a lot of control over. They know how to make money.
yes, businesses are in the business of making money. It's like
Right.
trying to convince you should buy a car, buy a Ford as opposed to a GM, as
Right.
opposed to a Toyota.
Exactly.
Um, Beers, clothes. There's also large marketing that's designed to make women feel bad about their bodies.
Exactly.
So they
Yeah.
buy dresses, makeup,
Yeah.
Botox,
Yeah, exactly. Yeah.
and so
And that's where, as doctors, I
there's
mean, I remember having a doctor who he had all this stuff up on his walls about antibiotics because people come in and they were
right,
dead set on getting antibiotics. They had a cold, but they
right,
wanted antibiotics, and he felt very
right.
pressured. And I know a lot of doctors feel very pressured. And now we're finding out, oh my
Hmm,
gosh, we have all these antibiotic resistant bugs as a result of giving
hmm,
out too many antibiotics. So but there's that
right.
pressure, and we now have the internet. So not only do we have advertisements on TV, but now I can go and look stuff up and say, oh, of course I need this. Come into the doctor and say,
Hmm,
I want this. And you're in a position of either saying
yes.
no or sure. And if you say no, you're going to have angry patients, which is problematic. Do they
Yep.
actually, I always
And
wondered if
so
in medical school, do they have a class for you to deal, like, to work with patients? Because I think that that's one of the hardest things to deal with is patients who are like, I want this medication.
um, no, but in training we do talk about service recovery. You get we get training on customer service. We
Right.
gotta get the same kind of training that the sales consultant, or the manager at the local store gets when you have a person who comes in unhappy. You're like, okay, how do I make them feel happy?
Right.
Or okay, they're angry. What you need to do is listen to them,
Right.
let them
Yeah.
run out of anger before they're willing to hear you. Say, okay, I'm hearing what you're telling me. I hear you saying this. hmm hmm hmm
Yeah. That
Okay,
that
stop
validation is
venting.
important.
How can I help you?
Right.
Yes. And so learning that stuff, but that's also, yes, the validation stuff is very important. So there is a lot of um, balancing, giving the patient what they think they want,
Right.
versus what you're perceiving as what you perceive as the best medicine, or if there's multiple ways to treat it, can you find one that is evidence based? Which goes back to the transgender thing. If people come in saying, I want transgender hormones, you're like, uh, yes, but you're not in therapy, you aren't out, and you have all this trauma.
Yeah.
I need you to deal with all this stuff. I'm sorry you're unhappy you're not getting
Right.
hormones today,
Yeah.
but you need to deal with all of that.
Right. And it's
Um,
interesting because I'm actually in a couple of groups for people who are
mhm,
detransitioning. And
right.
sometimes we get people who come in who are wondering if they should transition. And a lot of times they'll come to the group and they'll say, I'm depressed, I have anxiety, I think I might be autistic, I think I should transition. And we're all like, no, 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 no. Deal with all that other stuff first. And then if you still
Right.
feel that way, that's the time to start exploring it, but not until then,
Hmm.
because it's I always try to relate it to triage. If somebody comes in
Hmm.
and they're, they have a broken leg and they have a cut, but their heart's stopped, you don't go ahead and, deal with the cut. You deal with the heart
You
first.
feel heart stopping.
And
Hmm.
then you can look at the cut later. And that's kind of, but I feel like a lot of people are just, they have this idea that if I just get on these hormones, everything's going to be better. And I think a lot of that is due to the culture we live in, that people who do come out as transgender now, they used to be, as you said, kind of in the shadows, more marginalized. Now
Hmm.
we have, a lot of affirmation. People are really celebrating when somebody decides to start the
Yes,
transition. So it's a little bit different
right.
dynamic.
You, you can be on the cover of Vanity Fair
Right,
as.
exactly. Well, Dr. Roberts, I
um,
really appreciate all your
yes.
time, and especially for going so off topic, because I know that we sort of covered a whole lot of stuff that is really tangential to your
Hmm.
study. But I do want to thank you for doing that study, and I hope that you'll continue to do research in that area, because I do think that fairness in sports, as a woman, I'm very protective of these opportunities that so many women,
Hmm.
the scholarships that they get to go to college, um, opportunities that are created as a result of sports can be
Hmm.
life changing. It's not something I
Yes.
experienced as someone who is not particularly coordinated and who's small, but I do recognize that that it's an opportunity that women have
Hmm.
historically not been able to access. So I appreciate your insights on that.
Oh, you're welcome. Thanks
Yeah.
for chatting with me.
All right. Have a great day. Thanks.